5 grams of whatever liquid AD solution, and then 2 hours later you test that, your glucose plasma in the glucose in the plasma. And that should be, well, if you have diabetes, then that would be either greater or equal to 200. And then if the person presents with symptoms, so like hyperglycemia symptoms, or they're in a hyperglycemic state, then you can do a random plasma glucose, and that should be greater than 200 milligrams. So numbers you want to remember is just 6.5, 126, 200, 200.
Just remember the 6.5 for everyone.
Great. Oh.
All right, well, this slide shows us the goals of diabetes. The glycemic targets listed are for non-pregnant adults with diabetes. Our target is for our A1C is going to be below 7%. And by lowering the A1C below or around 7%, we can actually reduce microvascular complications and macrovascular disease. So on the bottom of the chart, we're looking to a more or less stringent targets, which may be appropriate if they can be achieved without significant hypoglycemia or adverse events. More stringent targets should be below 6.5 and less stringent targets should be below 8%. And just the trick for me, for the 7%, like 7 is my lucky number, and I do a thing where I repeat things 3 times for it to be instilled in my subconscious. So I'll say like A1C 7, A1C 7, A1C 7, and just remember the targets below are like 0.5 below and 1 above. So if you remember the 7 and the ranges 6.5 and 8, it should be pretty easy to remember.
So question for you guys, what would make you think to be more stringent versus less stringent with your A1C goal? Comorbidities, higher risk. What if I was an elderly patient?
Do your best.
Do your best.
With this type
Right?
of
So like,
like mechanism of action versus effects,
real life,
and
right?
then like where
80-year-old
to
Raina,
insert insulin
in
essentially.
my A1C when
So
I
if you
came
have to take
in
away
was
those two
9, and you're telling me I need to get to 6.5, I'm like, I'm never going to reach 6.5. I'm not even going to stress my life with that, right? So like,
That okay?
also with our elderly patients, and if you have patients who are very, they can be hypoglycemic very easily. Sometimes we have patients who are sensitive. You'll try to stay in that less than 8 until they get a hang of how they're going to do their treatment and everything, because you also remember hypoglycemia is just as bad as hyper, okay? So depending on your patient and depending on what's going on, don't give an unrealistic goal that seems unachievable, because then some people won't even try. If they come in and their A1C is at 9, 10, yes, ultimately our goal is to get them to less than 7 or less than 6.5, but give them something that they can reach, so then they will have that momentum to keep trying and keep getting lower and lower and lower, okay? For the exam, remember less than 7, you will see some where if I give you a question, I might tell you that their goal is less than 6.5, or I might tell you what their goal is, but if I just straight up ask you, less than 7 is what you'll see in most of your guidelines that you're looking at, okay?
Hello. So we're seeing here is our glycemic controlling agents. They're attacking at different areas. So to link the different classes with the medication. So the first one, metformin, your big guanide. So with metformin, that's the one I typically think of outside of insulin that's more associated with diabetic patients. So metformin is going to be the big one. Remember that one. Your SGLT2 inhibitors, we learned about that one during the heart medications. Just keep knowing that's your gliflosins. The DPP4 inhibitors, your gliptins. So I'm going to associate that one inhibitor with tin. So that one inhibitor with the tin. Your GLP-1 receptor agonist. So glucagon and glutide, so link those two together. Your TZD, your thiazolonidonides, glitazone. So zo and zo, link those two together to help remember it. And then the 3 remaining ides, we're going to link that with your SFN GLNs. And then the last one, the AGI, the alpha glucoside inhibitor, so arcarbose, so A and A, so alpha and arcarbose, link those two together. And then outside of that, insulin for your type 1 diabetics and some of the type 2s that these medications don't work with. Hopefully that helps. And then you can see here on this chart how all the different medications are attacking hyperglycemia just from different routes.
All right, we've got the pre-diabetes. So just note, anything less than 6.5 in the pre-diabetes range for A1C.
And then on this, I will tell you, because you'll have calculations that we're gonna talk about later. You'll see different goals for the fasting, and you'll see different desired goals that you want your patient to have. On the exam, I will tell you what those desired goals will be. So just understand that if you see this, and when we talk about the calculation, I will provide that to you if you have a calculation on one of those things. I will tell you what the desired range is gonna be, okay?
Lifestyle modifications, you got the classic low-fat diet, weight loss, stop smoking and drinking. Metformin is probably going to be the most common one that people are on. We also have the GLP-1 for those that are obese. One thing that helps me memorize type 1 and the medication that you'll need to use for when they do have diabetes is that there's a 1, type 1, and then insulin starts with an I, and they look similar. So it kind of helps me.
So, hold on, sorry. When we talk about pre-diabetes, please understand that sometimes your patient may not want to be medicated because they don't have the disease yet, okay? So it is a discussion that you can have with them. It's very non-invasive unless they're obese and you're using a GLP-1, which then they're injecting, right? But other than that, like our metformin, they're just taking a pill to try to not allow that A1C to tip over the 6.5 range, okay? So it is beneficial for them to start it. Can you make them do it? No, we can't make our patients do anything. So just be aware of what meds you're using in pre-diabetes, which are a little bit different, kind of, than what we're gonna use for our, like, you have to take this every single day because now I have diagnosed you with diabetes.
A1C is greater than 6.5, and then that means that they have diabetes.
And I added this because I want you all to remember what this looks like. You're gonna see it later, but understand patients who end up on insulin, even if they're a type 2 diabetic, you'll see like their insulin regimen sometimes resembles this, okay? So we'll have a basal insulin and then they have mealtime insulin. You can have just basal, you can have just mealtime. We'll talk about this, but like, just understand this is like a typical layout that your patients that you'll see will have, okay? Y'all are gonna learn more in a minute.
Type 1, other names for it, insulin-dependent diabetes mellitus or juvenile onset diabetes mellitus, again, because that happens, or typically shows up younger than 30 years of age, is autoimmune of the destruction of the pancreas B cells. That's why you need insulin, because they can't produce it. There's two main methods of injection for that insulin. You'll have the multiple daily injections, kind of what Major Hart just mentioned. You can do 1 or 2 injections of basal insulin a day, and then that'll be about 50% of the daily allotment. And then you can spread the rest of that other 50%, divide by 3, typically with each meal, space it out. Or you can use the continuous subcutaneous insulin infusion, CSII, which is that pump if you've seen on people like on their arms or other parts of their body that continually secretes that insulin.
All right. So for mechanism of action, you're going to replace type 1. Everybody knows why? Because they're insulin dependent. Type 2, you're going to supplement. Also, that big underline inhibits hepatic glucose output and glucagon secretion. It ultimately reduces the glucose. Adverse effects, obviously if you're injecting something, that's where you're gonna see issues with fat mass at the injection site, dimpling of the skin, also at the injection site. For drug interactions, obviously anything that interacts with blood glucose is gonna be bad if you're using insulin.
And so, remember when we talked, I keep saying that hyperglycemia is just as bad as what? Hypo, right? So if your patient, when you get a log back, if you keep seeing several hypoglycemic logs, like where they're writing that they're less than 70, then that should be your hint that you're dosing them, you're giving them too much insulin, or that they're not eating and they're still taking their insulin, which can sometimes be an issue for some of your patients, okay? So keep track of these hypoglycemic events so that you know if you need to dose, change their insulin dose. And then the other thing is also that weight gain. This is why we don't want to use insulin if we don't have to in some of our type 2 diabetic patients, because they do gain weight, and it is hard for people to, of course, get the weight off once they gain, right? So understand as we go through a lot of these meds, pay attention to the ones that cause weight gain, and then we of course have some that help with weight loss. Okay, so pay attention to that because we want to use those sparingly, especially if we have somebody who's already teetering that obese rate. Okay.
Still on us. What you got? Just the right.
All right, so for insulin, we're looking at routes of administration. We're going to do IV, intramuscular, or sub-Q. I didn't have anything for the absorptive effects. But clearance, you're looking at renal and hepatic. So if you have renal failure or hepatic failure, you're looking at the possibility of hypoglycemia.
So go back to the absorption and tell me like what are important counseling points that you would potentially have to tell your patient. If you're telling me I've never used insulin before, because remember some of these patients have never used insulin before, what are big things that you see there that make a difference?
Okay, so if you're giving at the site of an injection, it's going to be pretty rapid. So you want to make sure that you put it in your abdominal fat or posterior arm where you're going to have some fat, or the lateral thigh or the buttocks area. You want to inject it into the fat area, not into the muscle. And then after you do it, you massage it so it's going to increase the absorption.
Do you want to
You do
massage
not.
it or
You do not want to.
Do not.
But
So
they're
think
probably
about that, right? Because sometimes we'll tell people after we give them a shot, oh, move around more, massage it, right? This is the opposite of that. Because if they do that, all of our insulins are based off of something, right? I have short acting, I have rapid, long, right? I'm expecting for them to be released a certain way. So if I have my patient going now and they're massaging it, I just destroyed, right, what I'm expecting for my half-life to be of that insulin. So this is completely opposite of what we would typically tell a person once they do an injection. We don't want them to bother it. And understand that as they move those injection sites, which we want them to do, because remember our side effects that we talked about earlier, whenever they're saying if you keep injecting in the same site, bless you, you'll start to see like dimpling of the skin, they'll start to lose fat in that area. And so that's why we want them to rotate it. But as you rotate those sites, you see that it might hit them a little bit differently. If I have more belly fat, right, than the person who doesn't, or if I'm doing this side of injection very fast in my stomach, but if I were to give it in my butt, it's not going to be as fast, right? So like seeing that where they inject and how they choose to rotate plays a role in how fast that insulin is going to start taking place, okay? So if somebody is going to wait to eat and they're taking a rapid insulin right before they're eating, maybe don't put it in your stomach because you're likely to be hypoglycemic if you're going to delay how soon you're going to be eating, okay? So maybe it's better for you to inject in your thigh or in your butt instead of this area that's gonna be very, very fast onset, okay? So kind of thinking about all of those things to let them know, those are things that affect your patient. Those are things that can hit them in that hypoglycemic range to where it's not beneficial for them anymore, okay? And then there's one more that I want you to make sure that you cover, which is that picture. Can you tell me about the top picture?
So it's also on the last picture, you don't wanna put it on around the navel, so don't inject it into your belly button.
Make sure they're 2 inches around so that they can absorb it properly, all right? They have to be further away from it because if not, the absorption will vary and again, we have that same issue. The way that we made it now won't matter, okay?
Hey guys, group 2. The first question we had was, what are the 2 main insulin groups and what glucose levels do they target? So the 2 insulin groups were basal and bolus. The easiest way to remember that is basal is kind of like a baseline. So kind of your base insulin throughout the day when you're not eating. So you would give that as kind of a maintenance dose. And then your bolus, think like pushing a drug bolus, kind of almost like slamming it. That's going to be your to mimic your post-meal insulin spike. So if they need insulin, then you would give 2 different types. One is kind of a maintenance dose throughout the day when you're not eating, is your basal, and your bolus is your kind of, you take it with food. The ranges that we want to target for basal is going to be your 80 to 30 milligrams per deciliter, and then the bolus is going to be less than 180. Unless you have something to add to that, man.
So this is a very, 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 very important slide, okay? I am not gonna tell you what is rapid. I am not gonna tell you what is long acting. You have to know which insulin falls into which category, okay? So come up with whatever fun names you would like to come up with.
I got something for that.
Okay. Go ahead.
Well, it's a further question I have, but if you want to know it now, so.
You can do it later if you want to do it later. But in general, money maker test, you're going to see this, okay? I'm telling you, you're going to see it.
And that weird word, I had to look it up too, if you're not familiar, prandial. Prandial just means with food. So you have pre-prandial, post-prandial, pre-eating, post-eating. It just means with meal. This chart I hated, but the main takeaway was that obviously the bottom has hours, so the rapids are going to do a quick onset and then also a pretty quick offset, and then the basals are going to have kind of a slower decrease, longer half-life. So kind of choose your poison based on the goals that you want to get. These charts I also hated. The top one is normal. That's how our body is supposed to work. The vertical green bars is when we eat. When we eat and we get those carbs, the insulin spikes to kind of offset that glucose, and then it goes back to baseline. B is what was that one? Yeah, same thing. But there was we were short of insulin, so it has those little weird peaks. The C was how it's supposed to work with insulin treatment, so that's when we are giving those, that basal, that long-acting insulin is that basal that I talked about, the kind of all day, and then when you eat, they're going to give that bolus. So very similar to what we would have, but that's drug-induced. And then D is with the pump. So that's just kind of timed intervals of release to coincide with when we eat. There wasn't really a good way to break this down. I would focus on bold after looking at the slide for a while. Focus on the bold letters. The onsets and peaks, once you look at them for a few minutes, they make sense. The rapid acting is about half the time of the longer acting ones. So if you just look at it for a few minutes, and whenever you're studying it, 15 to 30, then 10 to 20, and then 25, like each thing kind of gets a little bit longer. Just note that the peaks and the onsets and the durations each get a little bit longer with each drug that you give. All of them are sub-Q, and the big thing to note was the NPH is cloudy and the rapids are clear. That's the big thing that I took away.
So with this, I know y'all are worried about exam questions and just in general how they work. So if you think about a rapid acting insulin, you're usually giving a rapid acting insulin so that it can coincide with how I'm taking my food, right? So you want it to be rapid. And I remember it saying like, I want it to be rapid, I don't want it to lag.
No lag before you eat.
Lispro, Aspart, blue lysine, right? So that I can remember that these are kind of quick. In general, they're about 20 minutes before they kick in and they start working. Do I need you to remember like 10, 15 to 30 minutes, and this one is 10 to 20? No, if you remember in general, they're working and they work pretty quick, around 20 minutes, like you said, quick on, quick off, and then you do have a peak. Because some of these, when we talk about them, they don't have a peak. So that's important, and then like you said, you're taking it before or very soon after. Most of the time, we tell our patients to just take it before they have their meal. And then the color is important. Used to be way more important back in the day than it is now because we now have mixed insulins that become pre-mixed. But if for whatever reason your patient has to mix their own insulin, they need to put the clear before they do the cloudy, which is one of our longer acting ones. So they do the clear first because it's easier for them to draw it up and see how much they need, and then they would put that into the cloudy. So that's why you see clear before cloudy if you did have to mix them.
That's a good question. Inhaled insulin, Alfreza, is rapid acting. The biggest takeaway I came up with was it comes in 4-unit and 8-unit cartridges only 4 and 8. It's dosed at the beginning of each meal, and it's usually used in conjunction with long-acting insulin, of course. So you take this with meals if they don't want to do injections or anything like that. On the other slide for group 1, they had intrapulmonary. That's what this would be. And on the slide it says, if switching from a sub-Q dose, you need to round up to the nearest 4 units. So if you have 6 units, you would round up to the nearest multiple of 4, so it'd be 8.
The thing that sucks for you guys about this drug is that most of the time you're going to require a PA to do it. Prior authorization, not EPA, like a prior authorization for it. So depending on how TRICARE feels, right, you'll have to try other things before we typically would put them on this because you see how much it costs. It costs more than our vials of insulin. So we're going to make the provider jump through hoops if they need to for whatever reason, or if the patient wants to do this instead of injecting themselves, okay? So prior authorization is required for this one.
And also be wary giving inhaled medications with people with respiratory issues. Yeah, this is everything I just said. Read it over in your free time. So the short-acting or regular drugs, so we went from rapid drugs to rapid onset to the regular insulin, and I remember that the rapid is, like she said, the no lag before you eat is the rapid, the bolus. The other bolus is the regular insulin, and I just, the R and the R, and said regular is not in a rush. So it's also considered a bolus drug, just as a slightly slower onset, slower peak. Instead of the 10 to 15 minutes, it's 30 to 60 minutes before eating. That's going to be your regular, but otherwise, kind of same concept. Your bolus drug to give with meals. It's a drug of choice for IV infusions.
So if you have a patient who comes in, pregnant patient, things like that, we like this because it's not as long as a long-acting, right? I can control it easier, but it's also not as short, and I don't have to use it so much how I would with a rapid. So this is kind of that sweet spot as to why you see that we like to use it. And then the concentrations, y'all are going to talk about in a little bit, but understand that this one is also one that comes in a more concentrated form. So if somebody has like very high doses of insulin, we're not giving them like huge amounts at one time. We can give them a more concentrated one with the regular. And you will see some people get pretty high up there when it comes to their insulin that they're going to have to inject. They don't care sometimes, or sometimes like they can't change that habit quick enough, and their A1C is still climbing, and you're still trying to control it. So you keep keep increasing their dose, they keep eating McDonald's and Burger King, okay? So it's kind of like you're trying to catch those things and modify the lifestyle. Eventually, it will change, so then your dose will then go back down, and you will change your dose for that patient, okay? So this is always moving, sometimes in your patient, until they are stable, right?
U500, I was still going with the drugs. U500, the only thing that I really took away from this slide is that it's typically only used in insulin-resistant patients, whether that's type 1 or type 2. It's really just a more concentrated U100, but instead of giving a bunch of fluid, a bunch of U100 doses, it's a more concentrated kind of dose. And you can actually break it up. So if it's 1 mil of U500, then you can do 0.2 mils, and it'll still be that 100 worth of dose. You can break it up. You don't have to give it all as one, so you can kind of concentrate it that way. But typically U500, I found that it's for insulin-resistant, severe diabetes patients.
Yeah.
Just to clarify, when it says the drug of choice for IV infusion, that's just strictly U100.
Yes, not the 500, yes.
Yeah, I looked at the slide for a good 5 minutes. I think it's FYI. Is this FYI, man?
So, when you're looking at this, it's similar to what we talked about, but I want to talk to y'all about this because this is a huge medication error that we see a lot. And usually on our side of the house, not so much your side of the house. So you guys will order, and because this vial looks similar to a regular human R, sometimes we will give our patient the wrong one, okay? But where we see we need you and for you guys to help is that the needles are different for the U500 versus your normal concentration, and we'll have a slide that kind of talks about that later. But understand that when you order a vial of insulin, you need to order needles. If you guys just give us a prescription for a vial of insulin, that's all we're gonna give them. We don't give them needles without a prescription. Even now, because of like drug users and all of that, even if you go to a Walgreens, it's not really a prescription, but sometimes a pharmacist will not release needles to a patient, even if they have a vial of insulin, okay? So you have to be very mindful. Anytime you do this, you need to do that, right? So if I prescribe insulin, make sure you're giving them needles, all right? So when you're looking at this, all this is telling you is you have a tuberculin syringe that you're gonna use, which is not the same thing as your U100 syringe. Your U100 syringes are units. This is an ml, okay? So not the same thing. So you can see where the errors can happen if you did order the insulin and then gave me the wrong needles, right? Because if I think that I'm pulling up 0.5, let's say 0.05, in actuality I could be pulling up 5 or 0.5 ml, which 0.05, sorry, ml, which is a huge difference. So this is talking about units. This is talking about like a unit of volume, okay? Not a unit of insulin. So when you see the other slides that talk about the tuberculin syringe, I want you to definitely pay attention to that because this is a big medication error that happens, one in the pharmacy because of the vials and the like, but on your end because you ordered the wrong. So tuberculin syringe, if you're looking at your U500, and just your regular U100 syringe if you're looking at any of our other insulins that we have. All other ones take U100 syringes, just your U500 takes the tuberculin syringe.
And that's just because it's a more concentrated
It's more
dose.
concentrated. So
Okay.
then this makes it easier for me to read on the syringe, and it's marked very clearly on the syringe, versus this, which is like saying 5 units. It's marked also different. I'll see if I can look at something marked.
Intermediates, it's going to be your
Are you doing group 2?
No, this is still group 2. I'm not done. You went out of order. I had questions to answer, and you didn't. NPH is intermediate. The easy way to remember is intermediate NPH. Okay, pretty easy. Once again, earlier the rapids, the bolus were clear. This is cloudy, and yeah, that's all you need to know. It's intermediate onset. Think of the name. It's intermediate. It's not as fast acting. It's a basal. It's a baseline. Next slide. You didn't go to long act. You're missing slides.
Hold on, are y'all three or not three?
They're three. Yeah, we're missing slides.
Well, because I deleted it. Okay. What? But it still has this, the slide numbers are, calm down. Okay? I'm not having
This is not. More slides.
So, this slide deck was 140 slides, so I deleted a lot of slides. So, if the numbers are off, it could be off because I deleted slides because I didn't need to know a lot of stuff. So, I'm trying to see if what was intermediate, or is that on your group 3 or it's not on your group 3?
It's on mine too. I'm gonna hand it off to group 3. Group 3. Way to go, guys. All right, so group 3, talking about these mixtures. Matt already went through the NPH and regular insulins. We'll be talking. Yeah, he also talked about the rapid-acting insulins. The next ones we have are the mixtures of protamine and the rapid-acting insulins. There are 3 of them, which she says you don't have to know the names, just know that there are different components to each one, and keep in mind the onset, peak, duration, timing, and compatibility. So these ones you don't want to mix with other insulins because they're already pre-mixed in this solution. The next slide. These ones as well. So these are 70% of the NPH and then 30% of the regular acting. 2 different brands, the Humulin and the Novolin. Same thing with these, keep in mind the onset, peak, duration, the timing and compatibility. Moving on to the long actings, these ones obviously have a different onset, different peak. The Glargine, Detamir, and Degludec, they have different administrations. These ones you also do not want to mix with other insulins. You also don't want to dilute these. The middle one, Detamir, highlight the fact that it's bound to albumin because it's different from the other 2. And then the next slide is.
Hold on, really quick. So this is what we were saying before, how this doesn't have a peak, right? This is the first one where you're seeing where it doesn't have a peak, which is why you're using it as basal, right? How you're saying like this is your baseline and it just stays that way. That's what this is doing. So the fact that it doesn't have a peak, whenever you saw those charts that we looked at, that's why it kind of just stays kind of in the background. If I don't have the beta cells to secrete that insulin, this is kind of like your safety net that's always in the back. And then your rapids are like, hey, I ate too much, or well, I ate in general, right? So I ate, and so your rapid is kind of covering that basal that's just there all day, because our body would naturally be kind of secreting a little bit of insulin all day, but because they don't have that, or because their beta cells are depleted, now that's what that basal insulin is doing. It's just kind of hanging out there for anything that kind of spikes or like a small little snack or something like that, okay?
So this is a good slide to have. This one splits it up based off of all of the insulins that we've talked about up to this point. On the far left side, you could see the top 3 are your boluses, the bottom 2 are your basals, and it splits them up by rapid, short, intermediate, and long acting. Onset, peak, and duration is important with all of these. lists them all out, but also the comments. So you can see that each of them have slightly different information that you need to know. One of the questions that we had was, why do we have premix insulins? And basically we premix them into these pens or vials to improve convenience, reduce injection frequency, and simplify it for our patients so they're not injecting themselves multiple times with multiple different types of insulin.
And then to finish out for group 3, we had, or we're supposed to talk about it, reiterating that anytime you order a vial of insulin, you have to order those syringes or else they won't come with them. And then the different pens as well, that each different mixtures, there's a bunch of different pens out there, but if you're going to order the pen, you don't need to order the syringes, but they do need to be educated on exactly how to use that. And generally they'll be taught their sliding scale based off of their issues.
So with the vials, we have the syringe, and then with the pins, there's pin needle tops. So there's like these little small pins that come in like it's just the top. So what they would do, they're individually wrapped. They open them and they click them onto the end of the pin because you can use that pin more than one time. Okay, so then they would put a new pin on that or pin needle on the end of that pin every single time.
They have a good picture of that on 44. The pin, the whole setup for the pin with the brick for the pin, slide 44 has a really good picture.
I had one. I didn't know how to put one in there.
One more. I'm sorry, one more.
Oh, yeah, this one. There. They look like this. Okay? So this is all in like a little container, and then they stick the pin into this, and then they can uncap it, and they inject themselves, they take it off, and they do that every single time they need to inject themselves. They'll get just a new little pin. Okay?
It has a neat little window on the side that shows you how much is left.
And all of these were, oh wait, hold on. This was the slide. What slide? Okay, so talk us through what we're talking about with this. The difference between your insulin one and your commercial one.
Oh, yep, that was highlighted on the slide all the way back to tuber, I guess that's right. The one on the right was specifically for dosing on the U500, and the one on the left is for the regular insulin. And if you get those backwards, you can greatly mess up their dose, give them a much higher dose than you were originally, or underdosing, which is also not ideal.
Alrighty, so group 4, we're going over insulin management. So we get to dip into some med math, which will be fun. The big takeaways from this slide are insulin is weight-based, and on average you're going to be looking at 0.5 units, not milligrams or anything, per kilogram. An easy way to do this math is find out what your patient's weight is in kilograms and then just divide by 2. Don't overcomplicate it. 2 considerations when dosing is if you got bigger people or little people, you want to either increase the total daily dose or lower it. Next for regimen, it's broken down into the 2 that Matt discussed earlier. You have your basal or your long-acting, almost like a loading dose, and then you have your boluses, which you'll take after each meal. So they're the rapid acting. You can split that conversion between 50-50 seems to be the recommended, but you can have some fluctuation between 40 to 50, 50 to 60. Quite frankly, whatever makes your med math easier and whatever helps with the patient compliance if it decreases the amount of doses they have to take. Looking at these, is there anything else for that slide?
For the test, let's do 50-50. Real life, it's way more complicated, but for the test, your basal will be 50%, and then your bolus will be the other 50% divided by like how many meals they have, so 3 meals. If I'm a person who eats 2, don't divide that second 50% by 2. It should still be divided by 3, but I'm only taking 2 of them. Does that make sense? So like, okay, so I have 100 units that I'm supposed to right? I need to take 50 of that for my bolus, and then I would divide, that was a horrible number to pick, divide my 50 by 3, right? Most people should be eating 3 meals a day. But if I only ate 1 meal, then I only need to do that rapid the time before I had that meal, whatever it is, breakfast, lunch, or dinner. I only need to take it that one time. If I ate twice, then I only need to take my rapid before those 2 meals. If I did it 3 times, then of course I would then use my 3. So don't feel like if they skip a meal, they skip a dose, is essentially what's happening with your rapid. Your basal, your basal should be taken all the time. But your bolus is because you are eating. Remember that graph at the very beginning, right? When we saw that they ate something, we saw that increase. And so we need the insulin to help with that spike of glucose. But if I don't have the spike of glucose, if I still take insulin, what did I just do to myself? What's going to happen to my glucose? It's going to go down, and it's already down. My phone was answering. It's likely going to cause hypoglycemia. Okay, so if I skip a meal, I skip a dose of my rapid. All right? Yes.
So how does that work with them having an average daily requirement? They're not meeting their daily requirement.
As far as their food goes,
You know, it says the average daily requirement of 25 units per kilogram. We're dividing it half is basal, half we're dividing up into meals. If they're skipping meals, then they're not meeting their total daily dose of required insulin.
well, this is based off of what that person is doing, right? So like this is, when you see the 0.5, that's telling you what your insulin dose should be. Again, it's an estimate, it's not specific, which is why you're saying like if you have a heavier person versus a smaller person, this number could be overshot for me, right? If I'm heavier, it could be too low for me. So when they come back to visit you again, you're gonna look at their log and say like, oh, this is way too much, you're riding low too much. Or you're gonna say, oh, this is too little because we're not getting you in that range that you're supposed to be in. So this average daily requirement is saying your person was ideal, which most of our patients are not, right? I eat once a day. So if I have to take rapid insulin 3 times a day, I'm gonna mess myself up with those other 2 doses because I didn't eat anything, if that makes sense. If somebody is eating once a day and then they eat like a huge meal, which is not a typical meal, then you're gonna have to start accounting for that too. Like, okay, you're overeating that one time that you eat a day. Now the typical dose that I would give you is probably not enough to handle all of the glucose that you're putting into your body in that one meal. So then that starts to shift on what your basal looks like and what your bolus looks like. So this is like a clean patient, which you will have a clean patient on the exam. Maybe they won't eat, so then you're gonna skip something, right? Which is why I said you skip a dose of rapid and you just eat a meal. But like in real life, this is all over the place, right? Because you can have a meal. Yeah.
How does that work if somebody snacks all day?
So again, they're long, and what you would be doing is adjusting their insulin times based off of when they were doing that, and it depends on what they snacked on. Also, if I'm on bolus, that's what my basal is taking care of. Because it's a snack, it shouldn't be a huge spike unless I ate a Rice Krispie treat or a slice of cake, right? Now my snack has caused a bigger problem for me. And then those are times where like you might have to have somebody where they do take another injection because they'll start to feel symptoms of the hyperglycemia. But that's why nutrition will be your friend with these patients. Because they have to learn how to snack, they have to learn how to eat meals the right way. So it's more complex. Exam-wise is exactly what he's telling you, like it will be clean 50-50, the second 50 divided by 3. So like that 16-ish per meal that they would have for their rapid, if they skip a meal, you skip that dose, okay?
Charts, we love them. So we're gonna focus on the bottom left chart, the basal bolus once daily. That follows the basal and bolus dosing, where you would have your basal dose you would take at night, and then during the day, breakfast, lunch, and dinner is when you're gonna take your bolus dosing. This leaves you with only really like 3-4 doses during the day, which is better for compliance. If you look at the twice daily basal, now you're looking at 5 dosings, which could decrease compliance. The above two, I don't know if you could validate this for me, but when you're taking both a basal and a bolus at the same time, does that increase your risk of hypoglycemia?
It can.
So there's greater risk factors with the traditional and split injections. So basal bolus once daily.
And this is just to show you more than one way to skin a cat, right? Like there's several different ways that your patient can present and need to have these. I'm not expecting for you guys to remember these pictures or anything, just understand like I'm giving them the basal for this reason, I am giving them the bolus for this reason, and my patient may present and need what bless you, need any one of them, right? And again, the compliance and what the patient wants is a huge thing, right? How many times do I want to inject myself? Do I want to inject myself at all? All of these things are questions that come into play when we're looking at how we want to do this. So just understand lots of ways. And really this picture, think about this one going all the way across, right? So like they take it at bedtime, but this should be going all the way across before it falls again to where they're taking it at night. So it's always in the background. Remember our basal is just hanging out.
Next up, we're going to get into the example. So starting with your patient's weight, we've got a reported 90 kilograms. Once again, you're going to do a recommended 0.5 units, so just cut that right in half and you're left with 45. The chart below kind of shows you how we're going to break it up, but 2 things to be aware of in the text is the basal dose is going to be recommended to be taken at night prior to bed. And then once again, your bolus doses are 15 minutes before each meal. So it's important to know that if patients are taking their insulin prior to eating, just be aware if they don't eat or forget to eat, it could lead to hypoglycemia. So if we're looking at the TDD, we are going to break it 50-50. So the basal dose is pretty set forth. Oh, we're going to go right into that.
Oh no, I thought it was, I felt it out. But I filled out the next one. Go ahead.
So your basal dose is just going to be your 45 units, and then your bolus dose, you're going to take 45 and divide that by 3. It's a nice number of 15 units for breakfast, lunch, and supper.
Right. So your total daily dose is 45.
Oh, sorry, I'm doing 45 as the half.
Yeah.
It's going to be 22.5, so you're looking at like 7.3.
So the big thing I want y'all to remember, because if you don't get a clean number, which most of the time you won't, we all know how to round, right? So how this said 22.5, but it was round up to 23. You have anything less than that, we round down. Yes, no. Yes, basic. So remember that when you're doing the calculations, because sometimes people forget how to round, and they round the wrong way, and they get the wrong answer. Okay?
Practice case. So TR is a 40-year-old male being converted to a basal bolus insulin strategy. His HbA1c was 9.2% and his weight was 75 kilograms today. Estimate this patient's initial dose of a rapid-acting insulin before breakfast. Assume a total daily dose of 0.4 units kg per day. So the 2 things from that is we're doing 0.4 units, not 0.5. And then it's also just the rapid acting insulin dose. We're not doing like the total daily. So the first thing we're going to do is multiply 75 times 0.4, which equals 30. You're then going to take 30 divided by 2, which will give you your bolus and your basal, which is 15 units. And then for your bolus, you're going to take that 15 and divide it by 3 to represent your 3 meals, and that's going to give you 5 units per meal for your bolus. So the answer to this question is, you guessed it, B, for 5 units.
All right, let's do our break. 10 minutes and then come back.
I thought we were at. What are you talking about? Her original deck. Her original deck was yeah. We were still all going on. Yeah. Yeah.
I don't doubt we did everything.
It was actually based at me.
The whole area.
Yeah.
Like one the whole area.
Things like why do you know if anyone
Correct? But if I get licensing, light blue,
This one will. So you always do use so in order to follow you say
I'm so confused with like Pepsi and if I had to mix my own, it's probably like way too much, way too much. I don't want to mix so much. Because I'm not lying.
there was no savings.
Because they don't know probably. And on the mix, you have to do clear noodles or before you do cloudy or
about the same thing. No, but yeah. But
Everyone that works. I like not being out. I got what So then, so like, if that's the
it only matters in the civilian one, right?
No, I know, but in type one. then I,
I told her that the life, these they're the ones that like allow you to work with them.
Yeah, so like if you get a license in one state, you have to be licensed in all
But
these
she wasn't sure which one, but I told her, look at the state.
Yeah,
These states are
but
showing
then
up.
Texas is like one of the hardest ones to get licensed for some reason. I don't know why. I don't know why. It's like one of the harder ones to get licensed. But all those licensed ones, if you have a license in one state, then you can practice in all the other states.
can I get a license in a state in which I don't live? Can I
But
do?
you need a doctor to sign off.
So like, so like, if yeah, so like, most of the that's that like, you have to get the doctor to sign off, which is why they have with us, first thing I see is, us, at least, like, let's see, because if you want to practice on the outside pretty much.
Forms that you have to allow, they request like to fund everything, like proof that you're graduated from the accredited.
Yeah, which I've seen people like I really ask if they get proof of organization, like degree-wise, and UNFC doesn't give they see your like our they can't call you an degree and you find like it also comes with medical. Yeah, so like I see people all the time like, hey, I need who do I contact? Like, I need not all the time. Like, always like Dr. Jones, the one who taught us to invest in food. That's the one that was teaching math. She was in a class. So I always see her when you reply like, hey, DM me, I will get that help you out. She's not going anywhere anytime soon. Yeah. So, but yeah. So when we get all this stuff, like we graduate, all this stuff, that's the thing. They say I want you. I want to see the layers of that. But that's so cool. Yeah, no, it's a think about it, but like for me, like
It is what it is.
I bet you some like food one
You're happy for all there?
I'm just worried. This man's leaving the ER return. I'm putting all my money in there. I'm putting all my money. I know you like ER he wants to do it, but I see.
Just kidding.
Accutane's really strong. You can't go outside, have to drink a lot of water.
I want cash oil.
Double birth control. Yeah, they want like.
I know
birth
it's very charismatic.
Yeah.
So like you can't. I think like yeah. I think even like the dose control. Like I know that.
You know, like,
I know
you
you're
need to
right.
sign like you have to do that.
Yeah, it's stupid like you're out of
One of my soldiers got like in the hospital for something. That was nuts. They can't figure out why. Like he was telling me his wife, like, no, I'm on Accutane. They didn't like put the two like
it's literally the size of a goddamn like.
it's just my provider was like, yeah, one of them was like, you're not gonna get on. You're not gonna drink it all. You're not gonna be on. I went to do it for birthday. I was want to have a drink. But like you're so like.
I'm like, bro, if you want your liver to become the size of a goddamn like.
But I thought I needed Accutane. And then I saw people come in with leaving this
I'm not that one.
and like 10 yeah, no, I'm trying to look at that, brother. They got the scar. When you start getting acne, you get the scar. That's like
I'm like, I never had like bad acne. I like, it's never like how bad it is.
I don't even call my
It's a little more like
cardiologist that I have to it's hard when you go from like
I don't know. Usually get more about it. Like how he was describing it, like how he's fucking like I'm going how is it? Yeah.
those are like those are the three things.
I think they were confused.
Yeah,
There was stuff that was all of America thought was pretty much rapping out there. It would be
that one I was like, he didn't say
there was another one added. Yeah, he said another one.
Real quick, everybody, we got 2 things to put out. There is a PT test on March 18th. If you are on profile, you need to send me that profile. I'm only tracking one person right now, or else you're going to have to do that PT test on March 18th. Then March 25th, we're going to do the height weight. So if you need to send me that profile, please send it to me so I can send it to them. But obviously, if you go on profile between now and then, go ahead and send it. If you need to update your, if you still need your tables or hours to maintain your certificate, you got to send that to me so they can do the whatever memo or whatever they need to do. But right now, I'm only tracking one person and one person. So if those apply to you, please send them to me because by the end of the day, they're going to go ahead and close those out. That's it. Thank you.
Thanks, Jake. Jake. Thanks, Jake. Thank you. Thanks, Jake.
Good. Ready to go? All right. So on this slide, we're talking about insulin to carb ratio. You can see there for regular insulin, and this is how many grams of carbs are covered
per 1 unit of insulin. How you get to that, your regular insulin, it's 450 divided by your total daily dose of insulin, and then rapid, you're bumping that up to 500. Estimated that every 1 unit is about 15 grams of carbs. As you get heavier, that ratio goes down. As you get leaner, it goes up. And then down there at the example, so we have total daily dose of 76 units. Sorry. So 500 divided by 76 comes out to about 7 grams per 1 unit of insulin.
Oh, 6,
Okay,
7.
so on this, again, you understanding what is rapid and regular is going to be your responsibility. I'm not gonna tell you like, oh, you're using a regular insulin or oh, you're using a rapid insulin, right? If I gave you the name of the insulin, then you should still be able to know it's rapid or it's regular so that you know which equation that you're using, right? Because they're two different equations. So understanding what goes into rapid, what goes into regular helps you then pick which equation you're going to use, alright?
Okay, so this one is corrective or supplemental doses. This is like, for example, if you have a birthday party and you ate your whole cake and now your blood sugar is sky high. You're gonna measure your blood sugar and it goes into this formula down here, current minus desired, which is usually between 100 and 120 or 125. Divided by the correction factor, which comes from just above it, regular versus rapid acting again. So 1500 or 1800 divided by your total daily dose. Plug that all into the formula, and that's how much insulin you need to take to account for your birthday cake or whatever else you just ate.
Okay, so this is in addition to, right? So that was a lot of the questions that everybody was asking about, like, well, what would I do if it was this, or what if they were still high, or what if they're, so this is like a sliding scale kind of for you to know, hey, I overdid it, or I overate, what else do I need to do to like add on to the dose that I'm already taking, okay? So this is in addition to whatever that bolus was that they already had, okay? So they took their glucose level, and it could be a fasting one, it could be also 2 hours after they already ate, but they took their glucose level and they saw that it was still elevated. This is kind of to supplement them to get them back down, alright?
And I just found out I'm doing this slide too. This is just, looks like just example of the previous slide to calculate it out, and this will probably be one of the calculation questions on the test. I wouldn't be surprised. Yeah, everyone can do math, so you can do math. Good to go.
Are y'all good on the math?
Can you explain it more, ma'am?
You'll explain it, go ahead.
Me? Whoever's holding it. Okay. Okay, give me a sec. Okay, so a 90 kilogram patient uses basal bolus insulin regimen. It takes 5 units aspart, 15 minutes prior to each meal, and he eats 3 times a day, and 30 units glargine at bedtime. So that's going to be his basal. His pre-lunch SMBG, something blood glucose. I don't know what SM is.
Like it's glucose.
Okay, keep going. His pre-lunch blood glucose is 160. His desired blood sugar is 120. What supplemental dose of aspart should you or he administer to himself? Okay, so total daily dose, you're going to
Right, so I'll walk you guys going to be the 0.45 of the, so you're 45 units. The other way that you could do this is, you see that they're taking 5 units prior to each meal, which tells you that, is that your basal or your bolus? Bolus, right? So then how many, what do I need to multiply that by?
3.
3. And then I said that they take largine at bedtime, which is my basal. So I can also do it that way. 30 plus the 5 plus 5 plus 5. So remember, everything that you get is going to be clean as far as how we're going to divide it and divide by 50 and then divide by our 30, okay? So that's how they got the total daily dose. Then it's saying what supplemental dose of Aspart should be administered. So Aspart, what is that when I'm looking at my factors that I have here? Rapid, right? So that's the same thing that's being applied here. So my 1800 divided by that total daily dose, which is giving me 40, okay? So then it's saying your corrective dose. This is what I was telling you guys before. I'm going to have to give you like what's going on as far as your current, right? Your current, we can see because they said that his pre-value was 160 and his desired is 120. So my 160, which is what you currently had, minus my 120, which I would tell you is their goal, right? So I subtract those two things, and then I'm dividing it by that factor that I got up here, my correction factor. So divide that by 40, and I see that my corrective dose is going to be 1, okay? So you're doing the same thing that we did with the other math problem, it's just your corrective factor equation is different, right? But it's still based off of rapid and regular, and you knowing which one is rapid and which one is regular. Yes.
Yes, ma'am. So for this example, if you don't give us it, should we trust that it's 50-50 for bolus and basal, because this one is not?
Give you what?
What they're taking for their bolus and their basal, because he's taking 2/3 of his daily intake as his basal, and then taking 1/3 for the bolus, not 50.
So maybe I'm not.
So his daily dose is 45 units, ma'am, according to this. 30 of it is the basal at bedtime, which is 2/3. So it's not 50-50.
I will tell you, when I told you guys about the math and doing 50 and then 50 by the third, that will always be what you're holding, unless I give you another number. If I give you these, like how this was given to you as 30 and then 5 and 5 and 5 because it's the rapid, then use that. But if I gave you just a random total daily dose, then you would be dividing by 50 and then dividing by 3.
50 divided by 3.
Yes. Yes.
Got it, ma'am.
Yeah, I almost said something else. Yes. If you're giving it this way, then use these numbers to know this is my basal and this is my bolus, because I would say this is the one that they were using at night, or I will give you a long or intermediate acting, which are your two options that you have for basal, and then I would give you your rapid that you would be using per meal. So then just add those together for your total daily dose. Don't do any other things to figure it out.
Sounds good.
Somebody have their hand up over here?
Figure it out.
Hello. So we come back to this same graph again. This one is pretty much talking how you do a little adjustment to your insulin. So if you look at number 1, it's talking about if your pre-breakfast blood glucose is high or low, you just have to adjust it. And how you adjust it, you're adjusting your evening basal insulin. And because throughout the day, for people that are diabetic, they will have to check their blood glucose level. So whenever you have a high or low, you just have to adjust it on your next or 2 doses later on.
So when we talk about this, we'll look at it a little bit more in the pretense of a Dawn and a Sanofi effect. But what this is saying is your patients are going to check their glucose level a lot. They're going to poke themselves a lot, especially when they are initially starting and you're trying to get used to what doses are going to work for them. So all this is saying is whatever, if you have a dose that you see like their glucose levels are elevated, you're going to fix whatever shot they were supposed to have prior to okay? So that's all this is saying. I don't need you to remember every single one of these things. Just understand that if I'm having an issue with my breakfast glucose level or my lunch glucose level, if I'm having an issue with my lunch glucose level, then that means that I need to fix what I did before that. If I'm having an issue with my bedtime, then I need to fix the dose that I gave before that. So just always, if you can remember, defer to the dose prior to, that's what this is saying. So it's my pre-breakfast blood glucose is high, or if it's low, I need to adjust my basal that I gave them that night before, because remember, that one should be lasting at least 24 hours. So what I should be seeing by the time that I got, before I had breakfast, pre-breakfast, that should be able to control me. If it's not controlling me, then I need to adjust that bedtime dose that I give, which is going to be my basal dose. So all of these are saying the same thing. If my lunch glucose is high or it's low, then that means that I need to look at my breakfast, right? Look at my breakfast basal, because maybe I didn't have enough, or maybe I gave too much, and that's why I'm high or low later, because it's still hanging around, or I didn't give enough insulin to control that, okay? So always defer to that injection that they should have given themselves prior to where your issue happened. Yes.
So the last couple of examples that we did are talking about adding insulin, and I guess my question is kind of like relevant to this in cases where we are talking about we have to do a dose of insulin, but I'm already like pushing being hypoglycemic, so I'm giving less of a dose. Are we expected to know like the reverse math of that?
No, and I don't think I understand. Like if they have too much, what you would do?
Like if I'm pushing hypoglycemic, but I'm not hypoglycemic, but I have to take a dose of insulin, like I'm about to eat or whatever, and I'm not like in my range of where I need to be because I'm below it. You know what I mean?
So then you would skip your dose. But I'm not expecting for y'all to do all of that.
But that's
The math questions are going to be like, literally like what you see on paper, right? I have to give you that information to plug into those formulas. I'm not expecting for you to be like a specialist on controlling, because hopefully we don't even see this a lot in our population, but I'm not expecting for you to be able to control everything. This is like dealing with blood pressure. There are lots of different ways that you can fix the problem. I am not teaching every single way to fix the problem or expecting for you to know all of the things. For the math, this is like to help with the sliding scale or to help this person be controlled. If they, in reality, like we're already about to be hypoglycemic, I wouldn't tell them to take their dose, or I would use that sliding scale and they would take less of what they typically would take because they're already low. So that's what would happen in reality. Am I making you calculate that? No.
So all we need to know is how to add insulin if they are hypoglycemic.
Yes.
Thank you.
Yes.
Just to clarify, so for implementing insulin replacement bolus regimen, is that one method versus doing insulin to carbohydrate ratio? Is that a different method?
Those are two different methods. Two different math problems, two different methods.
To treat their hypoglycemia.
Yes. Yes. So like if I knew that I was going out to celebrate my birthday and I'm gonna eat my whole birthday cake by myself and I'm not sharing, I probably am gonna need some corrective sliding scale to happen, right? Because that's not a typical thing that I'm doing. So now I'm gonna need to slide probably up a lot, right? To compensate for what happened. Those are, just remember two separate corrections that are accounting for different things.
Okay, and we're just going to focus then the insulin basal bolus regimen for this mostly. Or are we going to get tested on anything in regards to calculating insulin to carbohydrate ratio also?
So, you have looked at 3 calculations so far, right? You have 3 different things. Just understand what those 3 different ones are, and you will be fine. The insulin, the basal bolus is like a baseline of what anybody who's taking insulin, they're usually on some type of basal bolus. Those other 2 things are corrections in addition to this, right? They're in addition to basal bolus. So these are add-ons because I did something out of the ordinary, or I know that I'm going to do something out of the ordinary, or my body didn't respond how I thought it was going to respond that day. still like your primary way of you getting your medication. These are two supplements that you can add on to what I'm already taking. So those are three separate things, giving you three separate numbers. Right? So if I ask you that on the exam, I can ask you a question about any of those things. If you're still confused, ask me.
All right, so let's see here. Okay, so we have the dawn phenomenon versus Mogi effect. So it's pretty much a same from but different problem. So the key takeaways for this slide is just knowing the difference between the two. Fairly simple. So dawn phenomenon, you're taking too little of the evening basal insulin, which will lead to AM hyperglycemia. And in the Somogi effect, it's the opposite. So you're taking too little of the insulin, which will lead to hypoglycemia in the middle of the night. So what does your body do? Your body is going to undergo glycogenolysis and gluconeogenesis, which will eventually lead to AM hyperglycemia. So keep note that both these effects will lead to hyperglycemia in the morning. And the solution, fairly simple. So if it's the opposite. So if you're taking too little of the basal insulin at nighttime, you're just going to increase that dose. And same thing with the Somogi effect. Since you're taking too much of the insulin at night, you're just going to decrease that dose.
So what do you see as your determining factor as to how you can tell if it's dawn or Somogi? When are you checking the glucose level? Right? So that's whenever you can kind of see the difference in knowing which way you're going, which the dawn or the Somogi. Okay? So paying attention to those levels or where you kind of get the route in which you need to adjust your dose.
I guess there's a practice case. So it's the first time seeing it. I guess we're doing it as a class then. AB is newly diagnosed with type 1 diabetes. Started on an insulin regimen consisting of 14 units NPH in the AM and 7 units reg before breakfast and 7 units NPH in the evening and 7 units regular before dinner. At her next visit, AB complains of awakening due to night sweats, so I guess hyperglycemia at night, and being famished. She shows you her SMBG log, 0700, 140 over 160, or 140, 160, 12 o'clock, 85 to 120, 1700, 90 to 130, 2300, so around midnight, 90 to 120, and 0300, 55 to 70. What if anything should be adjusted to improve her glycemic control?
Right? So, yeah, so we need to decrease what she's having at night because she's hypoglycemic at that point that I was telling you that we're looking at. So between 2 and 3, because she's hypoglycemic, that's what we're experiencing. Or that's what we're experiencing right here, right? So if we go back here, this was saying between 2 and 3, she has the decreased glucose level. So if she's having the decreased glucose level, Mogi effect, what do I need to do? I need to decrease my evening basal. So that's how we get to C. Okay? So this is your determining factor whenever you're looking at this because it depends on where your patient is at that time. And yes, we tell them to wake up to check it so that we know unless they have a CGM. The CGMs are what we typically like will see our patients with on their arms. That's if it has alarms, it's connected to their phones. If they drop, it beeps really loud to wake them up. So this is also another way that they can be monitoring to see if that's happening. And you as a provider, you can get into their logs if they share access with you, and you can see what's happening with them throughout the day, 24/7. Okay? So that's another way now that we don't have to tell them to wake up. And if don't have a CGM, they're waking up to try to test between those hours to see what their glucose level is, so that you know what you're gonna change. Okay? All right, we'll